Okay, I think we're probably good to restart. Ollie, whenever you're ready, just go ahead.
Hi everyone. Rob, you tell me if ever there's any issues with my video or my mic. So
it's fine. Yeah, go ahead.
fantastic. All right. So hi everyone. It's nice to be back. For those who don't know me, I'm a 5-year grad from last year. I think starting to be fuzzy. And I am now a critical care fellow at U of M, and try to pop back in every once in a while to give a talk and say hi to my McGill family. So what I'm going to talk about today is the physiologically difficult airway. To begin, I obviously have no conflicts to declare because I'm not that important. Objectives will be to list the physiological changes involved in intubation, which patients may deteriorate because of what you're doing, and to know specific managements of patients that may deteriorate from intubation. So really, I'm going to start with kind of an intro rant, and for people who know me, that's not really my, my personality to rant all that much, but I'll give it a shot. Shout out to Joe Nemeth. Physiology of intubation very, very quickly, but I have to because I'm in ICU. We'll talk about the patients and then some take-home measures. So fairly easy. So to begin with, I'm just going to leave this here. Give it a minute. So with regards to the anatomically difficult airway, a lot has been written, a lot is being taught, and honestly, that's a good thing, right? It's recognized as something that's dangerous that we need to be aware of. That's a good thing. That people need to put a lot of effort in training and maintaining competence. That's a good thing, right? So if we look at the data, right, we're actually realizing that the more and more we go forward in time, the more and more we realize that the difficult airway is an important thing to address. And the more and more technology follows, right? The glide scope came around 2003. We're getting better, right? If we use the Crike as the yardstick for how well we deal with difficult airways, and that's a stretch, I understand, but overall, I'm trying to say that we're getting better at dealing with the anatomy of the difficult airway. Now, that's a blast from the past, but here is, this is taken from my Rosens. Those are my annotation. This is chapter 1. This is chapter 1, airway. And this is the amount of space out of 24 pages that's given to what I would consider physiologically difficult situations. Not much. And fine, it's addressed in other parts of Rosens, but what I'm saying is that it's not an entity, right? It's not recognized. It's not like, it doesn't have the fame as the anatomically difficult airway. So we should make a thing out of it, right? And then people will be like, well, we have a rhyme, therefore we're taking this seriously. And I'm not making any fun of people saying that because I'm the first person to say that. But I don't think that we do enough to recognize the entity that is the physiologically difficult intubation. That's my spiel. So again, with numbers, 35% of patients, of critically ill patients, will desaturate below 90% with intubation. 23% will have hypertension. And then depending on which patients you look at, sick or less sick, but there's a significant amount of people that have a cardiac arrest. Obviously not all of them die, but just saying that these are actually scary numbers when you actually put them down on paper. And we know that it's, it's also all associated with longer hospital stays and other comorbidities. So, why don't we have book chapters about this, courses, algorithms, all of this? We do, but not as much as the jealousy that I'm developing with the anatomically difficult airway. So, my point is respect the physiologically difficult airway and let's make it a thing, quote unquote. End of rant. How did I do? Let's talk about physiology then. We're causing a lot of harm to very sick patients. We throw drugs at them that will cause them to exacerbate their hypotension. There's certain side effects. I'm just, naming a few in there, I'm not listing the whole slew of side effects. We're paralyzing patients, which causes a significant amount of harm too, because let's say you have a hypotensive patient that's been really depending on their venous return. All of a sudden, they're not breathing anymore. Their venous return decreases. Or a patient that's severely acidotic, they really need that breathing, right? Our paralytics also cause a whole slew of issues for people still using succinylcholine. What I would term as laryngonephrine. So for patients that aren't properly sedated or not enough sedated or didn't get some kind of anesthetic, shoving a metal blade in their throat can cause them to spike their heart rate, spike their blood pressure. And if you have a bleed in your brain, or if your aorta decided to dissect itself, that's not good.
Sorry, just to interrupt. Just to interrupt for a second. The audio is a bit choppy. I wonder if maybe you try turning off your video. It would be, it might be a bit smoother.
I will do that. If anything, it'll make the presentation even better. So I was talking about, Rob, can you remind me where the audio cut off?
Yeah, you were just at the laryngonephrine point.
Okay, so just to reiterate how shoving a piece of metal in someone's throat that's not well sedated or anesthetized will, skyrocket their heart rate, their blood pressure. And if you have any situations that require a very good control of these parameters, well, then that's a problem. You're causing harm. With the switch to mechanical ventilation, right, we're switching to positive pressure ventilation. So in the hypotensive patient that depends a lot on their venous return, that's an issue. You might set an inappropriate minute ventilation. So for our COPD patients or for patients that are in severe metabolic acidosis, you need to be able to set the correct minute ventilation. We often forget about the RV, but mechanical ventilation is not great for the RV. So something to always keep in mind. And you might actually exacerbate shunting by causing more zones, which is kind of like a physio trivia question. But my point is we're doing a lot of harm, right? And the goal of what we do in emergency medicine and critical care as well is basically to cause a bunch of short-term harm for hopefully long-term benefits, right? So how do we mitigate the harm? How do we, if we know that we have to harm the patient by our interventions, then how do we mitigate? So the patients. It's a little bit ironic how I start with a rant by saying that we don't put enough attention to the physiological difficult airway, and then I figured that I can fix this whole thing by doing a 40-minute presentation. So yeah, that's not going to work, and that's why it's part one. So what we're going to cover in what I hope to become a lecture series are the following: the hypoxic patient, the hypotensive, the acidotic, the RV failure, the sympathetic sensitive, as how I describe it. It's a term that I'm coining. So if you ever hear it in used in more famous literature, then you can say that you heard it here first. The bronchospastic, and then the little adult, which by me referring to them as little adult completely disqualifies me to talk about them. But I just want to say that they do exist as a completely different physiological entity, and to be taken care of very seriously when you're intubating. So for today's lecture, I think it's best to try to narrow down to the hypoxic and the hypotensive, which are really like the main bread and butter of most intubations, if anything, but of physiologically difficult airways. And really what applies to these situations pretty much can be applied to all other situations, minus obviously certain caveats. There's always caveats. And voila. So hopefully, I mean, this is more of a raise awareness type of talk. There might be a few things that I'll be able to teach you, but it's really kind of a review and a raising of awareness on a topic that's dear to me. So let's start with a hypoxic patient. Hypoxia is bad. Good, everyone on board. Peri-intubation stats of less than 70 are associated with arrhythmias, collapse, brain injury, cardiac arrest, and we know that first pass success is associated with less adverse events. So what we are trying to aim in a patient that's hypoxic is to try and keep time in our mind. And it's kind of difficult because you're trying to pre-oxygenate the patient as best as you can, and that takes time. But you also have a hypoxic patient that might be desaturating as well. So it's a matter of figuring out, you know, what the best balance is. But as far as the anatomical part of the exercise of intubation, this is one of those situations out of all these patients that I named where you want to get a first pass success and relatively quickly. Now, quickly doesn't mean rushed. And the old adage of slow is smooth and smooth is fast kind of applies in these situations, right? So first and foremost, you got to set up yourself for success, and that starts with positioning. With the advent of video laryngoscopy, we're getting a lot better at dealing with anatomically difficult airways. Great, but what people tend to forget is that you're still trying to pass a tube from the person's mouth to their past their vocal cords, and that's not a straight line, right? To set yourself up for success, you have to try and make that as much of a straight line as possible, even if you are using a video laryngoscope. And I think a lot of people forget that, right? If you don't align the axes of the aura, the mouth, the pharynx, the larynx, you'll have a great view with the video laryngoscope. You'll have a great view of a failed intubation. So always, you know, align the axes. That's really a key. And how you do that is really you flex the neck and you extend the head. That's how you should start all positioning. And it might look exaggerated, but you know, I would much rather look like I'm exaggerating, but getting my intubations correctly. So, you know, the quick, you know, rule of thumb is the ears above sternum, and hopefully they'll align the axes very well. You know, video is better than direct laryngoscopy for first pass success in all comers. I understand that there are caveats. There are patients that are vomiting. There are patients that are bleeding. That, you know, if you, except for these couple of patients, and you have to keep them in mind, I agree, video is just better, right? You have much better chances of getting your intubation on the first try. So do consider video most of the time. I'm not saying all the time. There's always caveats, like I said, but video in the context of trying to get your first pass success is simply better. Bougie is your friend. right? There's a lovely study by Driver recently, 2017, that was looking at first pass success using bougie, and it does increase your first pass success. So it's something to consider. It does, increase your first pass success at the detriment of maybe a longer duration, and in a patient that's hypoxic, that's obviously something to consider. But again, you have it as your friend, keep it close by, right? That's all I'm going to say about just anatomical intubation. Now we're just going to go over more physiological settings for a hypoxic patient. You try to maximize time before the saturation. How do you do that? Well, it's basically a function of supply and demand, right? For a normal patient that hasn't been pre-oxygenated, their apnea time is about 40 to 60 seconds or something like that. So pre-oxygenation helps you extend that quite significantly. But that will depend on how well you supply that oxygen and what the patient's demand is, right? So a patient that is moderately ill, that has more and more and more metabolic demands than someone who's just walking in the street, they will desaturate faster. A child is another perfect example because their metabolic demands are very high and they will desaturate very fast. So it's a matter of what's going on, what their demand is, and how well you can provide oxygen. So how do we, in terms of how to process, how do we fill the tank, and how do we decrease their O2 consumption, if at all, right? Now, keep in mind also that if we're always basing ourselves on the pulse ox, it lags, right? And it lags even more in hemodynamically unstable patients, right? You're talking about a 30 to 60 second lag time. And in some of our sickest patients, they can desaturate in 23 seconds. So you're always behind the ball if you're just looking at the sat. So maximizing our time before desaturation. So filling the tank. So, well, the easiest thing to do is just crank up the FiO2, right? The concept of 100% FiO2 is an interesting one. Hey, we'll just put on the non-rebreather mask, we'll be good. So here's maximal ventilation that men and women can achieve. And it's easy to remember because it follows basically income inequality, 100 to 70. I know, bad joke, but I had to say it. The non-rebreather mask is basically plugged to the wall and it'll provide whatever the wall tells it to. And then depending on your institution, we all know that it can go above the 15 liters and it's usually up to 60, but more around 30. So 30 liters a minute. The maximal minute ventilation that I'm providing are in healthy people, obviously. So maybe that's less than that, but you see that there's a discrepancy, right, of what a human can achieve and what a wall oxygen source can achieve. So where are they going to get that extra minute ventilation? Well, they're going to get from the ambient air, right? So their FiO2 is going to be diluted and it's going to drop. Now, let's actually be a little bit, tedious in the physiology. The air that's coming in, the 100 liters that is coming in is during inspiration, right? The patient isn't inspiring over the entire minute. They're inspiring roughly about half if they're breathing pretty fast, ratio of 1 to 1. So 30 over the whole minute, they'll spend about 30 seconds breathing 100 liters, and then the other 30 seconds, they're expiring that 100 liters. So really, the air that needs to go in, the oxygen that needs to go into that patient is 100 liters in 30 seconds. So the flow that needs to come out of the wall should be 200 liters, right? So really, your effective FiO2 can be anywhere from 100%, and it never really is 100% because of valves and other issues, but it could be really 45 and sometimes even less depending on how good your wall source is, right? So a single source of oxygen in your very sick patients with very large minute ventilation is simply not enough. right? You need to have at least 2 sources. My 2 picks would be either the combination of a nasal cannula and a bag valve mask, or the non-rebreather and the nasal cannula. So that was my point about the multimodal kind of approach to FiO2, okay? Increasing the oxygen reservoir. So how much oxygen is actually in the human body? So at room air, these are relatively the quantities that are in the human body. And if you increase to 100%, you notice that your functional residual capacity really has a huge amount of reservoir capacity. And not only that, but we can modify the FRC. We can increase the FRC depending on our positioning, right? So this is one of the best ways to increase our reservoir, is basically, obviously increasing the FiO2, that's a given, but increasing our reservoir will involve just moving the patient around. And you don't need to move them that much, right? Some of the studies that have been done, and they're actually pretty decent RCTs, not a huge amount of patients, but that's the classic of anesthesia studies. You get 100 seconds extra from 100% SAT to 95% SAT just by placing a patient at 20 degrees. That's for all comers. For obese patients, that's about 50 seconds to go from 100 to 90%. By that study was about 25 degrees. It's really not that much. Most of these studies were just looked at raising the back of the patient with their feet horizontal. But I would argue that especially the obese patients, your pregnant patients that have a lot of weight that they're carrying, if you're just kind of like bending them in half, the legs that are the legs will prevent the abdomen from dropping down, which is what you want. You want the abdomen to drop down and give the extra space for the FRC. So I would argue that just the reverse Trendelenburg is probably the better of the solution. So increase the FiO2, increasing the oxygen reservoir, increasing the mean airway pressure. That's not always necessary, but it's an additional tool that you can use, right? What it'll allow you to do is, at least maintain, or if not increase your FRC. And by maintain, I mean that the body basically takes up oxygen faster, or at least more than CO2 is released. And that's actually what allows apneic oxygenation to work, right? That there's more O2 coming inside the body, leaving the alveoli, but the CO2 kind of stays buffered in the blood. There's actually not that much that actually goes out. So there's a net negative pressure that allows air or oxygen to flow downwards. And then, so increasing your mean airway pressure will favor that and will actually combat what's a term called denitrogenation atelectasis. In normal people that have a bunch of the normal air with nitrogen, the nitrogen will keep the alveoli stented. But if you replace everything with O2, you have a tendency to cause more atelectasis. Anyways, so it'll maintain or increase your FRC. It'll shorten your time of pre-oxygenation. There's a study that looked at expired O2, which we obviously don't have in the eMERGE, but your expired O2 was a lot higher with increased mean airway pressures. So using PEEP or CPAP. It's really your only treatment for people that are shunting, right? So patients with terrible pneumonia, and you just simply can't get their SATs above 90. Well, then they will need some kind of positive pressure to try and get that extra 10% if you can get it. And depending on what settings you choose, there's really not that much of an impact on gastric insufflation. The numbers out there for insufflating the stomach is about 20 to 25 centimeters of water. So if you're setting a PEEP of 5 or a PEEP of 10, you're nowhere near that. There, that's what I was saying. Your options to create CPAP or a PEEP. So your high flow nasal cannula is a great option. It'll create a bit of a PEEP, about like 2 to 3. And what's great too is that it provides humidified oxygen at very high flow, so it's a lot more comfortable for your patient. The problem that I find with the high flow is that it's difficult to combine it with something else. And sometimes it can be a bit cumbersome when you're intubating and kind of gets in the way, but it's still a great option. Another good option is basically putting in a CPAP mask, and then the CPAP mask will allow you to put the nasal cannula and use that multimodal strategy that I was saying. My personal favorite, but then you have to speak with your RTs because it involves a bit of finicking, is using a bag valve mask with a PEEP valve. So the PEEP valve attached to the exhalation port is basically what's going to allow you to create that mean airway pressure. And what's great is that you can combine it with the nasal cannula. You can give some assisted breaths if you need. And then this is a modified bag. This is the Weingard special, where you attach a manometer so that you make sure that you stay under that 20 to 25 centimeters of water to avoid gastric insufflation, and then an end-tidal CO2. So that's really the Cadillac of all bags. I don't know why people say Cadillac, and I don't think Cadillac is that great of a company. Anyways, but it's one of the better options if you've talked to your RTs and all that beforehand. Just a caveat. So PEEP is only provided if your exhalation valve is open, right? That part here, there's a valve in there that'll only open when you exhale. And so the PEEP, your PEEP valve will only work when that valve is open. But you don't want PEEP throughout. You basically want PEEP throughout your respiratory cycle. You don't want PEEP just through your expiration. So to maintain that valve open is having that nasal cannula at full flow, and it will basically allow a little bit of air to come out of that valve and for that PEEP valve to do its work. And I see that Dr. Mendelson was saying that the super bag is available in all rhesus area and MUHC, and that's fantastic. I didn't know about that, and I didn't know about the name, and I think it's a fantastic name. There we are. So we talked about this, we talked about that. Apneic oxygenation. Do it. I don't think I have to convince a lot of people. In anesthesia patients, just 5 liters a minute of nasal cannula gave me this advantage. If you looked at obese anesthesia patients with just 5 liters of nasal cannula, again, a significant advantage with your apnea time. Now in sicker patients, if you look at meta-analyses, there's obviously, so for your severe hypoxia events, it didn't quite make the mark, but I think it's such a cheap, easy solution to increasing your apnea time that I think anybody would be almost faulted not to use it anymore. I'm reading the comments. For Nina, current climate of pandemic medicine, is a PEEP valve bagging a safe option? What is the safest in this context? What you can add is basically add a filter. You can add a filter. I forget where exactly. Maybe Dr. Mendelson can say, but you can add a filter on the exhaust port to prevent any virus expiring. There we go. Now, decreasing the O2 consumption, and that's one of the most fun parts I discovered making this talk is we all use oxygen to make our bodies run, obviously. And in certain conditions, that O2 consumption is significantly increased, right? Muscle use and sepsis, malignancy, sympathomimetics, all of these conditions will increase our O2 consumption and will make our apnea time much shorter. Now the question is, well, there's not much that we can do about malignancy acutely. But in other situations, there are things that we can do. And actually, there are things that we are doing to the patient that makes their O2 consumption worse. And that's basically with their muscle use. Rock versus sucks. There is a lovely study by Tang in 2011 that basically looked at the apnea times of rock versus sucks. And once they desaturated, how long it took to recover. So using rocuronium, their desaturation, patient in the OR, desaturation until 92% took about 329 seconds, about 50 seconds longer than sucks. And recovery was not as big of a shocker, but there is a difference, right? And it makes sense. If you're using succinylcholine, basically you're fasciculating all the muscles in the body. That uses oxygen. Your apnea time is going to be a lot shorter, right? So to be considered in your hypoxic patient, right? To maybe favor rocuronium versus sucks. I thought that was one of the coolest part of making this this talk. I really liked it. So our strategy, if we go to our 7 P's of RSI, well, first of all, the first thing I would do is basically start with the positioning, because there's no point in ramping your patient after you've pre-oxygenated them, right? You can't pre-oxygenate and then all of a sudden increase their FRC and expect that it's going to have an immediate effect, right? You have to position them properly, increase their FRC, and then you can pre-oxygenate. So sniffing, ramp. My personal take is that I would use nasal prongs and something else. A super bag would be great. But if your RTs or if you yourself are not necessarily comfortable with that, then a non-rebreather is fine as well. I didn't talk about it, but ketamine for DSI, if your patient's agitated. Video, obviously having more success for your first pass. Keeping a bougie close by and decreasing your O2 consumption. So rocuronium and specific therapies for, I was mentioning like seizures, for example, treat the seizures because that's obviously using a lot of O2. What about bagging? So the pros is avoiding respiratory acidosis, although, respiratory acidosis in most of our patients isn't that big of a deal. Obviously, your metabolic acidosis patient, that's a big deal. Your brain injury patients, that's a big deal. But otherwise, saying that you will absolutely want to bag the patient to maintain their CO2 at respectable levels is not that great of an argument. However, maintaining alveolar distension and maintaining a little bit of their oxygenation by keeping their alveoli distended, yeah, that's a good argument. But there's no point in hyperventilation, right? The ventilation is more of a CO2 parameter, if I could say it that way, right? The point is maintaining an airway pressure. Cons, gastric insufflation, and positive pressure ventilation in your hypotensive patients. Well, so where do we make the decision? Well, I think that it depends on your patient, right? If you have a very low risk patient that you've managed to pre-oxygenate very well and you don't expect them to crash, then they really don't need bagging. for your high-risk patients, the patients that are shunting, the patients that you never really manage to get their saturation at an acceptable level, then that might be a more suitable situation for bagging, right? So that's my take. Hypotensive patient. All right, hypotension is bad. 23% of transient hypotension will occur in normal patients after intubation. In 30% of critically ill patients, they'll have a hemodynamic collapse after intubation, right? And hypotension is associated with just longer ICU stays and mortality. Cardiac arrest is strongly associated with hypertension. So obviously something to be very aware of. Another thing that I'm aware of is Rob telling me that I have 10 minutes left. So I'll try and hurry up. One thing that I'm adding here as a nifty little thing is the shock index. So the shock index has actually been associated with badness in peri-intubation periods. So normal is 0.7, right? It's your heart rate over your systolic. And a pre-intubation shock index of 0.9 is associated with post-intubation hypertension and cardiac arrest. So if you have a patient that's very tachycardic, but not yet hypotensive, you can expect them to suffer from the harms you'll cause them with intubation. So you need to prepare them appropriately. It's crude, obviously, but it's just like a quick, rapid bedside evaluation of the severity of their hemodynamics. Obviously, be aware of your extremes of age, your beta blocker uses, and all of that. So now, what your patient is hypotensive or they have a high shock index? Well, you need to evaluate them, right? You need to figure out what's causing their issue. It's kind of easy to put them in little categories, but understand that all these categories have very specific physiology behind them, and they can all be treated differently and need to be treated differently. So keep that in mind. And how are you going to go about this? Well, usually ultrasound is your go-to. Obviously, having understanding your history and physicals and whatever parameters you have at your disposal, but ultrasound is going to be able to discern very quickly and very effectively between these major causes of shock. So with regards to hypotension, I think we're pretty good at taking care of these patients, and there's stuff that's just very well accepted, right? If you can delay the harm that you're going to cause to the patient. Again, sometimes your hands are tied and you just have to intubate them, and that's okay. But if you can, delay your intubation so that you can improve the patient's hemodynamics. If they need volume, give them volume. And if you have a trauma patient, then you're going to give them blood. If you have a septic or a completely patient with a lot of GI losses, and maybe some crystalloids. Pressors, I think we've learned over the past couple of years that too much volume is not so good. Too much fluids is not so good. And probably we should jump on the pressor bandwagon a bit early in our patients. I think it's one of the changes that I've had in my practice where I've refrained from using too much volume, and I've very quickly jumped on pressors. A favorite of mine is push dose epi. But if you already have a levofed drip at the ready, that's good as well. Push dose epi will be able to help you titrate them. These two molecules are more favorable, I would say, to the typical neosynephrine. I like the first two because they have some inotropic effect, right? And you want to cover your bases. The phenylephrine, if anything, will just make your heart work harder. it works well in the anesthesia suite because patients are relatively healthy, and the cause of their hypotension in the OR is really because you vasodilated them, and that's what they need. But yeah, I think my go-to is something with a little bit of a inotropic effect. And then, you know, sprinkle some stress dose steroids if you have a refractory shock and you really have no if you have no good effect on your medical therapies. So that's for the kind of easy stuff. And now I just want to talk a little bit about the controversial stuff. And then awake intubation. I'll give my caveat right away about awake intubation in that I think awake intubation for a anatomically difficult airway should be done with the assistance or should be done by an anesthesiologist, because that's what they do, right? That's why you need them for. And awake intubation for an otherwise easy, difficult anatomical intubation, but a very difficult physiological intubation, that should be in the realm of our specialty, and I'm perfectly happy with supporting that point of view. Ketamine versus edomidate. I mean, I'm not even talking about propofol and Versed in shocky patients, for obvious reasons. Ketamine versus edomidate. So ketamine has the advantage of being a dissociative agent, right? So you'll maintain a bit of their respiratory drive and their airway reflexes, whereas etomidate less so. Ketamine, there's the added advantage of releasing endogenous catecholamines as long as they still have endogenous catecholamines, because the problem is if they're completely depleted, and then you're just basically giving the dissociative effect, you might still have some hypotension with ketamine. And then it's associated with its other side effects. Etomidate itself, I mean, it's a sedative, so not as bad as propofol and Versed, but it is a sedative. So it's associated with the issues of sedatives with their hemodynamic issues. Obviously not as bad, like I said. And then there's the issue of adrenal suppression, which there was a few studies that showed that it was associated with more mortality, there was associated with significant adrenal suppression, longer ICU stays. But, you know, you look at more study and really what it does. So first of all, there's a Cochrane review that shows that it's not associated with mortality or ICU stays or more vasopressor use. What we do know is that the effect of etomidate on the adrenals is that it does suppress them. You can measure it, but as far as patient-oriented outcomes, there hasn't been a significant impact, or at least it's reproducible in the literature. So it does and it doesn't. And I'm talking about one-shot etomidate. I'm not talking about an etomidate drip or sedation in ICU, obviously, just for intubation purposes. Now, head-to-head, there was a retrospective study that just came out, just I think in July, that was looking at post-intubation hypotension between ketamine and etomidate. And apparently there was more hypotension with ketamine, but it's a retrospective study. You know, the ketamine patients were a little bit sicker as well. So I'm not sure what to make out of this. I wouldn't rule out ketamine in and of itself because there's a perfectly good RCT findings in EMS literature, but it showed absolutely no difference. So I think either or, honestly, all of this to say that either or, they're very good agents. But I would edge towards ketamine because of that preserved respiratory drive, which leads me to the hemodynamic neutral intubation from Scott Maynard, and this is a very, like he says, an evidence-free zone, but it is a nice physiological exercise to go through. Again, for a difficult anatomical airway, awake intubations should be done with the anesthesiologist at your side or by the anesthesiologist. As far as a easy or relatively easy anatomical airway and a physiological difficult airway, then that I think is where we have our place with awake intubations. Now this is an awake intubation with some modifications, but basically the crux of awake intubations is topicalizing the airway as early as possible and as much as you can, depending on whatever what source of lidocaine you have. You do it as much as you can, and usually a combination will do well. So either a spray and viscous lidocaine on a stick under the tongue, or over the tongue, sorry. Consider glycopyrrolate, because the problem is if you have a lot of secretions, and especially if you're going to use ketamine, if you have a lot of secretions, then it's going to be difficult for the lidocaine to actually topicalize the airway. The glycopyrrolate is going to dry the airway, but the glycopyrrolate is also going to cause some tachycardia. So if you're really worried, then just use some good old gauze. Positioning and pre-oxygenating, as you would for anybody. You're going to titrate ketamine slowly to dissociation. You're trying to maintain the patient's breathing because their venous return depends on it. Then using video laryngoscopy and bougie, you spray as you advance. Basically, you don't want any impact of your blade on their hemodynamics. And after you pass the tube, basically what you set on the ventilator is a pressure supported 0 and a PEEP of 0, as if you didn't cause anything to the patient except put a tube in it. Again, this is no evidence whatsoever. This is more of a physiological exercise to think about. But do think that you have other options in your patients that are hypotensive than just completely sedating them, completely paralyzing them, and putting them on a ventilator. That will cause harm, right? So I know that Rob is starting to get angry, but here I am at the end of my talk, and there we go. So respect to physiologically difficult airway, mitigate the harm that you are going to be causing. Pre-oxygenate using multimodal strategies, please. Using pressors early, ultrasound is your friend. That's it. And I will still show my video because I will make you suffer through whatever I have to suffer in the morning looking at the mirror.
Thank you, Ali. That was, if there's any questions which were left. There was a question about using the diastolic blood pressure and the shock index, but there's an answer from Dr. Melanson about that.
Yeah, and I second whatever Dr. Melanson says. I've never really heard of anything like that.
Okay, awesome. So we look forward to having you back for part 2 at some point.
Mm-hmm. Part 2 and probably part 3.